Welcome everybody. We're going to talk but there's a two-part talk here. 4 years ago I gave the whole talk, but nuclear medicine's moved on so quickly that I'm going to cover the basic principles of radiology, and then my colleague Najib's going to give you all the fancy stuff afterwards. So the one take-home message from today is X-rays. Everybody now piles in, they see an infection, oh, I'll order an MRI, I'll order a CT. Please, 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 a plain film is key. You think it's too basic, but it's not. When your patients come back, as they inevitably will, to your clinic time and time again, you're not going to get a fresh MRI every time they come, unless you work somewhere that I'd like to work. You're going to get an X-ray every time they come, and that's what you're going to use for your comparison to see, is the condition deteriorating or is it healing? So please, you must get a baseline X-ray. I know they're often normal for several days, for several weeks, until you start to see the signs here that you're all going to be very familiar with. We do perform CT purely because it allows us to reconstruct in all the different planes. It's great for bone unless you've put a whole load of metalwork in there, in which case you do get streak artifact. But with the newer technologies, we are managing to reduce that, or hoping to achieve that. It does give you poor soft tissue detail, so it's only really good for the bone, and we tend to use MRI to get the soft tissue detail. Of course, there's a radiation dose that the MRI doesn't have, but it is very useful in chronic osteomyelitis because finding the sequestrum and the sclerotic changes is much easier on CT than it is on MRI. Ultrasound, rarely used. You can't assess the bone marrow. The only thing it's useful for is for joint effusions, subperiosteal collections that you might want to stick a needle in and try and get an aspirate from to guide your microbiology. MRI is the most common. It's a requested modality. I like the professor tells you to order the right test. Nothing makes a radiologist's blood boil more than somebody out picking the phone up to them saying, I ordered this test and you haven't done it yet. You don't order a test, you request one. Thank you. MRI, metal susceptibility artifact, is a big problem. It's supposed to be less now with our metal reduction sequences. It all seems to be very patient dependent and very dependent on what metalwork you've put in as to how bad the artifact will be, and you'll see that in some of the slides after. You have to remember as well, downside, a lot of these patients are diabetic. They can't have IV contrast because they've got renal function problems, and IV contrast is quite key in discerning what's infection and what isn't. And then you've got this problem of, is the high signal you're seeing on your MRI, is it reactive edema because the bone's been exposed for months, open to the environment, or is it actually active infection? And MRI used to be the only modality we had for trying to assess this, and it's not good. You basically cannot distinguish between these two entities, although we try. So this is an example of when not to MRI. You can see the amount of metalwork. I like that Paul's going to say you sprinkle some antibiotic dust in. I comment to my plastic surgical colleagues that they must have tripped with the iron filing pot or something, and they've just sprinkled a load of clips in there. How can you possibly have that many small blood vessels that you've put a clip on? Because it ruins my MRI. So thank you. So here's an example. You can see the X-ray on one side with the metalwork. You can see basically that MRI, you get no meaningful information. Yeah, I can tell you what's going on at the wrist, and I can tell you what's going on in the elbow, but the bit you're interested in, sorry, can't help you. So these are just some examples of some cases that we've done. This chap had a blast injury out in Africa about 20 or 30 years ago and presented with recurrent infection to us. Where's the problem? Is it at the top end where the screw is? Is it in the mid-shaft of the tibia? Where are we going? So here we've used CT, and you can see nicely the bony sequestrum as in here. So you can see that nicely. That's the beauty of the 3D reconstructions. You can reconstruct them in any plane you want. And again there, that's just in the axial plane. If trainees work in York, the only things they send you are the axial slices, and you then have to try and use your vivid imagination to make the coronal and sagittal reconstructions. Good luck. This is another one where, again, the patient's had a nail in at some point. The nail's been removed, the fracture's healed, but he's got infection with a draining sinus. So this is chronic osteomyelitis, and you can, again, see the little bit of dead bone. If you don't get that bit of dead bone out, you're going to be back in there again and again. This is the same patient with the MRI. You can see the beautiful soft tissue contrast. So you can see the abscess out the back, which is tracking as well, actually into the bone itself through the cloaca. So that's good as well. You can see the bone and the soft tissue components in this one very nicely. You get chronic cavities, again, more plastic surgery, iron filings sprinkled in liberally. You got your cavity, and they say, is this chronic, or is this actually active infection? Well, you do your CT, can't really say, none the wiser that there's a cavity. Yes, is it active infection? No idea. You do your MRI, you've got your chronic cavity, and you say, is it infected or not? Well, there's no edema in the rest of the marrow around it, so probably not. Gut instinct says no, but can I categorically prove it on the MRI that that's not active infection? No, I can't. Post-frame infections, Hemant and Ross are delightful. You know, they send me these patients and they say, which hole am I over-drilling? Which hole is the problem? Am I going to have to tackle the full thing? You don't really want me to take that screw out that's almost going to be impossible to get to down in the syndesmosis, do you? And then we do the MRI and you can see, well, all the screw holes light up. Which one is the one that's actually the infection? Which is the one to target? Or am I going to have to open the whole tibia? So in summary, throw everything at it. We tend to do everything in the bone infection unit. We start with x-rays, they get a CT, they get an MRI, and then when we don't know what we're doing, we get Najib and his nuclear medicine guys to solve the problem for us and guide us. But baseline x-ray, key. Get the scans done right, and you have to get somebody to report them who's used to looking at them, because otherwise everything gets over-reported as, yes, it's infected, when actually it's not.